as Pradeep sir did say in his introductory remarks, actually, since even though the burden of COVID has come down a lot, but then long COVID continued to be a problem, not only for us, globally, it has been recognized as a major challenge. The reason being that, the immunopathophysiology of the long COVID, even though a lot of research has gone into it, is not clearly understood, and also the treatment modalities are not clearly defined as far as long COVID is concerned. When Dr. Anju asked me to present something on COVID, I thought that the right thing would be to present something on long COVID. We had read a lot of articles on long COVID over the last 2 years or so. And this a brilliant review article was published on 13 January this year in Nature Reviews Microbiology. So when you're looking at the journal, shows that the Nature has a very high impact factor of around 76. If you want to know the impact factor, the impact factor of our JAP is 0.3, and of Nature Reviews Microbiology is around 76. So it's a high impact factor journal, and the authors are also well-established people from the research collaboratives in US. And this article has around 210 references, means that all the clinically relevant articles on long COVID over the last 2 years have been encapsulated into this review article. And the title of this is Long COVID, the Major Findings, Mechanisms and Recommendations, and they basically delve deep into the immunopathology of the various manifestations of long COVID. A few words on the topic per se. Long COVID, or the post-acute sequelae of COVID-19, is often debilitating illness that occurs in at least 10% of SARS-CoV-2 infections. This percentage actually varies depending on the severity of the SARS-CoV-2 infection. So if you are taking in hospitalized patients, people in ICU, etc., around 70% will be having long COVID. And even in the WHO database, more than 200 symptoms have been identified with impacts on multiple organ systems. Around 65 million individuals worldwide are estimated to have these long COVID symptoms. And interestingly, similarities with other viral onset illness, such as myalgic encephalomyelitis, which is otherwise known as the chronic fatigue syndrome, which we are all familiar with in the context of infectious mononucleosis, and postural orthostatic tachycardia syndrome. Sports have laid the groundwork for research in this field. So POTS means that some of the patients after recovery from COVID-19, they do experience autonomic symptoms like the postural hypotension, the postural palpitation, tachycardia, etc. So all these things are well described following other viral illness, especially the EBV, etc. This review explores the current literature and highlight the key findings, the overlap with other conditions, the variable onset of symptoms, long COVID in children, and the impact of vaccination on the occurrence of long COVID. I won't be touching much on the long COVID in children because per se it is another huge topic. And when we are looking at the published literature, these are supposed to be the risk factors for long COVID. One is the female sex, diabetes mellitus, the reactivation of Epstein-Barr virus infection, the presence of specific autoantibodies, connective tissue disorders, then attention deficit hyperactivity disorder, chronic urticaria allergic rhinitis. Means that any patient with an autoimmune milieu, if they develop COVID-19, the chance of them progressing to long COVID is very high. A third of people with long COVID have no identified pre-existing conditions. Lower socioeconomic status has also been identified as one of the risk factors for development of long COVID. The female sex and lower socioeconomic status, majority of the studies say that the chance of them getting rest during the acute COVID-19 is likely to be lesser. And that is the reason why, they are likely to have symptoms persisting for a long period of time. Now, looking at the immunology as well as virology, why some patients develop the long COVID symptoms, why in some patients the symptoms persist for months or years together, etc. Now we know that based on the available literature, the reason is linked to our immune system. Studies looking at the immune dysregulation in individuals with long COVID who had mild acute COVID-19. So majority of the means the inputs in this article is going to concern patients who had only a mild COVID-19 now and who went on to develop this persistent symptoms. Okay, even in patients with mild acute COVID-19, studies have found that there are T cell alterations, T cell dysregulation is there, T cell exhaustion is there. Reduced CD4 and CD8 cells might persist for up to 12 months. So this is one of the reasons for the persistence of symptoms. Multiple studies have also found elevated levels of autoantibodies in patients with long COVID, including autoantibodies to ACE2 and the multiple receptors. But then a major comprehensive study which was published recently said that even though autoantibodies are present, multiple autoantibodies are present in those with long COVID, they do not constitute a major component of the long COVID symptomatology. Another interesting hypothesis is the reactivation of viruses, including Epstein-Barr virus and HHV6. We know that Epstein-Barr virus, another expansion for EBV is everybody's virus. So majority of us, we get to experience this herpes group of viruses during our childhood. That is why our IgG will be positive. It has been found that after, say, chronic viral, after this acute infection with SARS-CoV-2 virus, in a subset of patients, there is a reactivation of this Epstein-Barr virus, HHV6, etc. And this has been tied to mitochondrial dysfunction and might contribute to the symptomatology of long COVID. And this EBV reactivation is associated with fatigue and neurocognitive dysfunction in patients with long COVID. And this is one study which was published a year back, which said that immune dysregulation is persisting for 8 months, can persist for 8 months following initial mild to moderate SARS-CoV-2 infection. And this study also showed that the T cell exhaustion as well as the CD4, CD8 cells, etc., might remain low for at least around 8 months following even a mild COVID-19 infection. And now coming to the concept of viral persistence. Viral persistence means, interestingly, in patients who are having these lingering symptoms, the biopsy studies from multiple tissues, including the gastrointestinal, endothelium, etc., found that the remnants of the virus or the viral protein fragments are persisting in patients with the long COVID syndrome. There is several reports have pointed towards possible viral persistence as a driver of long COVID symptoms. As viral proteins or RNA has been found in the reproductive system, cardiovascular system, brain, muscle side. That's basically, it has been isolated from almost all tissues in patients with the persisting symptoms. In one study, the spike protein antigen was found in 60% of a cohort of 37 patients with long COVID up to 1 year after acute COVID-19. And GI biopsies have indicated the presence of virus suggestive of a persistent reservoir in some patients. And this is an interesting study. And we know that we have a lot of patients who develop this inflammatory bowel disease, may present with abdominal pain, and imaging might show the thickening in the ileum plus the presence of the mesenteric lymph nodes, etc. This following COVID-19. Okay. And this, we assumed that it is actually a transient inflammatory bowel disease, which is occurring as a part of this post-COVID symptomatology. And the patients usually respond to steroids. That is how we approach, the inflammatory bowel disease which occur after COVID-19. Obviously, after ruling out other etiologies like tuberculosis. This study showed that in patients who are having this inflammatory bowel disease after COVID-19, they did large intestinal as well as small intestinal biopsy, and even after 7 months, they were able to demonstrate the viral protein as well as the viral fragments from the small intestine as well as the large intestine, and immunofluorescence was also positive. That is the expression of SARS-CoV-2 RNA in the gut mucosa 7 months after mild acute COVID-19 in 32 of 46 patients with inflammatory bowel disease following COVID-19. Viral nucleocapsid protein was also present. And interestingly, the viral persistence was unrelated to the severity of acute COVID-19, the immunosuppressive therapies used initially, or to the extent of gut inflammation. The post-acute sequelae of COVID-19 were reported from the majority of patients with viral antigen persistence, but not from patients without viral antigen persistence. So probably, and in all these patients, they tried to culture the virus, but they were unsuccessful. Means that it may not be a live virus, and rather viral remnants or viral fragments are leading to this sort of a problem. And our body might recognize these fragments as foreign body, and probably a localized auto-inflammatory or an autoimmune response is the reason why these patients are developing this inflammatory bowel disease and associated symptomatology. And these are the hypothesized mechanisms of long COVID pathogenesis. One is the, as we discussed, immune dysregulation, persistent infection, viral replication, reactivation. So this immune dysregulation can occur with or without the reactivation of the herpes group of viruses like EBV or HHV6. The second postulated mechanism is the alteration of the gut microbiota, which includes the alteration of the gut virome as well. Then third is autoimmunity and immune priming. So that autoimmunity and immune priming can occur as part of molecular mimicry. That is, in the case of inflammatory bowel disease, our body will identify the viral fragments as a foreign body and might mount an inflammatory or an immune response. And the reservoir areas where you can have this viral persistence happens to be almost all the tissues in the body. And second, we know that, and the fourth mechanism is we know that COVID-19 is an endotheliopathy and can lead to the macrovascular as well as microvascular clotting abnormalities due to alteration or activation in the coagulation cascade. And the formation of the microclots is supposed to be one of the reasons why, majority of the patients might have the persistent exertion fatigability, but the saturation might be normal. And then the dysfunctional neurological signaling, especially in the brainstem or the vagus nerve. And these are the symptoms and the associated pathology. We know that the long COVID can affect, or the symptoms might occur in any organ system. If you look at the cardiovascular system, the patient might present with chest pain, palpitation, and we know the mechanism. That is, it could be due to the cardiac impairment due to virus per se, autoimmune mechanism, inflammatory mechanism, or due to myocarditis, or due to macular infarction, etc. Can also be due to postural orthostatic tachycardia syndrome. And the persistence of cough or exertional dyspnea could be due to the abnormalities in the gas exchange. We know that the majority of the patients, their subset of patients can develop diabetes following COVID-19, and that's due to the affection of the pancreatic beta cells. And then when you're looking at the immune system, we know that autoimmune manifestations are very common in patients with long COVID. One interesting aspect is actually MCAS, that is mast cell activation syndromes. We also had patients, and majority of you also would have seen patients presenting with urticaria or urticarial vasculitis following COVID-19. And now the postulated mechanism is supposed to be the activation of the mast cells. And looking at the GI tract, the patients can present with abdominal pain, nausea, and the mechanism is supposed to be gut dysbiosis or as described, the viral persistence. And then the neurological system, we all know that the patients might have a lot of issues like, the brain fogging, that is a cognitive impairment, the fatigability, disordered sleep, memory loss, tinnitus, etc. And the mechanism, the reason for all these symptoms are supposed to be dysautonomia, then myalgic encephalomyelitis, neuroinflammation because of activation of the glial cells, reduced cerebral blood flow, small fiber neuropathy. And the kidney, spleen, etc. are also affected. You're looking at the the blood vessels, and the patients might develop coagulopathy, DVT, endothelial dysfunction, microangiopathy, microclots, pulmonary embolism, and stroke. And a lot of focus is now going into microclots because by the usual imaging modalities, we may not be able to identify the microclots, and scientists are looking at ways to identify microclots. And even the reproductive system is affected because the ovaries as well as the endometrium, the penis, etc. also have ACE2 receptors. And as part of long COVID, we can have this erectile dysfunction, reduced sperm count, etc. And this is one of the initial studies which look at. We all know that as a part of long COVID, everybody is really concerned about myocarditis or increased incidence of this myocardial infarction occurring in patients after recovery from COVID-19, and the risk might persist for years together. And the mechanism could be due to a direct viral toxicity, due to increased inflammatory markers. It could be due to the thrombosis and vasculitis due to the endotheliopathy, as well as due to autoimmune markers. So the cardiovascular sequelae includes the myocardial infarction, ventricular injury, myocarditis, which could be due to virus per se, it could be due to the inflammatory markers, or it could be due to autoimmune mechanisms. And this study, which we have discussed many times, this is also included in this review article. So this was published, I think, in 2020. That is, the cardiac MRI was done in athletes in USA. And even following asymptomatic COVID-19, myopericarditis was observed through cardiac MRI in around 7% of individuals. We know that, so definitely, even asymptomatic COVID-19 can lead to myocarditis, which may not be obvious by our ECG or echo, etc. If you are doing a cardiac MRI, around 7% of patients, even following a mild COVID-19, might have myocarditis. And that is probably the reason why we say that those who are recovering from COVID-19 should avoid vigorous exercise for a prolonged period of time. And another thing is the most interesting aspect as far as the neurological aspects is concerned is what we discussed as a brain fogging or executive dysfunction. And recently, one study actually, found the parallels with something referred to as a chemo fog. That is, those patients who are administered a cancer chemotherapy also experience a cognitive syndrome or cognitive dysfunction, which is very similar to something which is experienced as part of long COVID syndrome. And this is also due to activation of the glial cell or multicellular dysregulation. And the marker for this is CSF cytokine CCL11. So basically, they have identified the mechanism why some patients do develop this executive dysfunction, which is otherwise referred to as the brain fogging following COVID-19. And this study, so majority of the studies which looked at the impact of long COVID are from the Veterans Affairs electronic record systems in USA. So basically, it is something similar to our ECHS system. The only thing is that they have proper electronic health records. So all the available data or all the available studies on long COVID are from countries or systems which are having an electronic health system, well-equipped electronic health system, like say Denmark, UK, and the Veterans Affairs system in USA. So this study also shows that almost all the the anxiety disorders, depressive disorders, etc., the hazard ratio is close to 2 for like COVID-19. Means that COVID-19 does take its toll on the psychosocial as well as the mental health issues of patients who recover from that. And this is actually looking at the data from the Veterans Affairs electronic record system in USA. So we know that after initial infection, you can see that hazard ratio for pulmonary embolism is around 3. Hazard ratio means that a patient who is having COVID-19 has around, say, 3 times increased risk of developing an embolism compared to a patient without COVID-19. Also, the chance of them developing cardiac arrest, heart failure, death, stroke, etc., is higher than a patient without COVID-19. The same thing applies to the patients developing dysautonomia or this myalgic encephalitis, etc. Recently, a preprint has been published from the same group, showing that the patients with multiple COVID-19 infections, so breakthrough infections and repeated episodes of COVID-19, the risk of them developing this long COVID is actually higher than the risk following a primary infection. That is, if you are getting, say, COVID for 3 times or 4 times, the chance of you developing all these complications are likely to be higher. And this is from the same group looking at the cardiovascular outcomes of COVID-19. They followed up the patient for, say, 1 year and found that the hazard ratio for all these events, like, say, a stroke or, say, TIA, atrial fibrillation, myocardial infarctions, thrombotic disorders, arrhythmias, etc., definitely the hazard ratio is 2 to 3 in patients who recovered from COVID-19. And one of the most interesting aspects of the long COVID is the patients presenting with a non-specific symptoms. They will complain of excessive fatigability. They will complain of the lack of concentrating ability, etc. So this has been grouped together. These sort of symptoms has been grouped together as a MECFS. That is myalgic encephalomyelitis or the chronic fatigue syndrome, and the dysautonomia. That is a postural orthostatic tachycardia syndrome. So it's a multi-system neuroimmune illness. Is considered as a neuroimmune illness with onset often following a viral or a bacterial infection. Means that it is not specific to SARS-CoV-2. Usually it has been described following Epstein-Barr virus infection. Also in certain cases of dengue fever, West Nile fever, etc., and following bacterial infections like Q fever. The definition is very interesting. A substantial reduction or impairment in the ability to engage in pre-illness levels of occupational, educational, social, or personal activities for at least 6 months, accompanied by a profound fatigue that is not alleviated by rest, along with post-exertional malaise, unrefreshing sleep, and cognitive impairment or orthostatic intolerance. And we have treated a lot of patients, and all of you have treated a lot of patients who had symptoms suggestive of chronic fatigue syndrome. Many researchers have commented on the similarity between this and long COVID, and around half of the individuals with long COVID are estimated to meet the criteria for chronic fatigue syndrome. Reactivation of herpes virus like Epstein-Barr virus, HHV6, 7, CMV, etc., are associated with the development of chronic fatigue syndrome. And both POTS and small fiber neuropathy are commonly found in long COVID syndrome. So we know that autonomic system can be affected by SARS-CoV-2 virus infection, and those patients with paroxysmal orthostatic tachycardia syndrome, one mechanism is the small fiber neuropathy. And this is a summary of the treatments which are being considered, and majority of these treatments, these are not really accepted, which has been piloted in some trials. For example, post-exertional malaise, the treatment recommended is actually pacing. Pacing means that you have to plan your activities in such a way that the activity and the rest times have to be pre-decided. That is something known as pacing. For a postural orthostatic tachycardia syndrome, also, if you identify the syndrome, there are pharmacological measures like beta blockers, fludrocortisone, midodrine, pyridostigmine, etc. And we usually use fludrocortisone. If there is no response, we go with midodrine. And immune dysfunction, if you are able to identify that, the CD, if there is a B cell dysfunction or say T cell dysfunction following COVID-19, probably IVIG also might have a role in that. For cognitive dysfunction, the suggested one is actually the cognitive pacing. Then for fatigability, the coenzyme Q10, because one of the reasons for fatigability is supposed to be the mitochondrial dysfunction and alterations in the mitochondrial metabolism. So coenzyme Q10 can be tried. And pain, fatigue, neurological symptoms, etc. If there is no response to your usual modalities, then naltrexone has been advocated. The fatigue and all, and unrefreshing sleep, brain fog, and all, low dose of aripiprazole. And abnormal clotting and all, we know that if there is evidence of clotting, definitely anticoagulants will help. An interesting aspect is that they say that if you are able to identify this viral persistence, probably a treatment with Paxlovid might help. But then that is, if you are having symptoms persisting for months together, you can try antivirals, because it could be due to viral persistence, and the studies have been done with Paxlovid. In the study I showed regarding the viral persistence in inflammatory bowel disease, etc., they were not able to identify the cultural virus. So if that's the viral persistence, means the persistence of a live virus or viral remnants, and will it respond to Paxlovid, etc., is not clear. But still, it is something which can be tried out. Then if you are able to identify the reactivation of viruses, probably antivirals like say valacyclovir, famciclovir, etc. might help. For endothelial dysfunction, the pilot study with pseudoxide is going on. Pseudoxide is actually a combination of heparan sulfate and dermatan sulfate. For GI symptoms, probiotics have been tried. Dysautonomia, which is not responding to your midodrine or say usual modalities of treatment, stellate ganglion block can be tried. For endothelial dysfunction, microclots, oxidative stress, etc., this pycnogenol is actually the pine bark extract, which has been tried. It is very rich in bioflavonoids. For mast cell activation syndromes, like patients who are developing hypersensitivity reaction or say urticarial vasculitis, which means a response only to steroids, etc., famotidine may be one of the options. Now, coming to the effect of vaccines, suppose a patient is having a long COVID symptoms like say polyarthralgia, brain fogging, etc. What will be, suppose the patient is due for a booster shot and all, or a second dose of vaccine, etc. Will you give vaccines or will you differ from giving vaccines? So my gut feeling will be to differ the vaccines, because vaccines can also act as an immune trigger and probably can lead to worsening of the symptoms. From all the discussions, we know majority of the the symptomatology or the manifestations of long COVID are probably due to a dysregulated immune response generation, autoantibody, etc. So I won't take a risk in giving vaccines. But what does the evidence say? The impact of vaccination on long COVID symptoms in people who had already developed long COVID differs among patients. Around 17% of the patients will experience a relief of symptoms, whereas 21% of patients will experience worsening of symptoms. For the remainder, there won't be any change in symptomatology. So that is what the current evidence says. Then what are the important take-home points from this article? So the important take-home points appear to be that mild cases that result in long COVID often have an underlying biology which is different from acute severe cases, but the same type of tests are being used to evaluate patients. There is no for a long COVID, no patient is presenting with say exertional dyspnea or say polyarthralgia after COVID-19, which is persisting for say months together. The usual evaluation will include the CRP, D-dimer, ANA, etc. These are the tests that we usually do for acute COVID as well. Okay, but in majority of the cases, patients may be having symptoms, but these investigations are likely to be normal. And they suggest that tests that return abnormal results in patients with a chronic fatigue syndrome and dysautonomia happen to be tests which measure the total immunoglobulin levels, the natural killer cell function test, the tilt table or the lean test for diagnosing POTS, the salivary cortisol test. The studies have shown that in certain group of patients with fatigability, the cortisol levels may remain low for more than a year, which is due to the affection of the HP, hypothalamo-pituitary adrenal axis. The reactivated herpes virus panels means that your fatigability is not improving despite a supported treatment. Probably you may have to look for the quantitative PCR for HHV7, Epstein-Barr virus, etc. Then for patients with POTS, if your TIL test is positive, then you can go for a small fiber neuropathy biopsy. And the test which has been proposed is actually the corneal microscopy. You can look at the small fiber density, the nerve density in the cornea. And tests looking for abnormal brain perfusion, etc., and cardiac MRI. These are the tests which should be prioritized. So means that we have to those patients who are having lingering symptoms, and if your usual tests are normal, we may have to evaluate patients in this line. And I would like to end this with this slide. That is, this image is actually from the UK Biobank. The UK Biobank looked at, studied the cognitive dysfunction in patients following mild COVID-19. And they found that there is a decrease in the brain oleum, the parahippocampal gyrus and orbitofrontal cortex. And there is a sort of a brain atrophy as well. And that is, even the imaging studies showed that there is a distortion in the brain oleum and all. However, they are able to identify this. The UK Biobank actually, is sort of a cohort, and they have the stored MRI, the brain oleums, etc., of a cohort of patients. And they selected patients who had this imaging and then developed COVID-19, and they followed up with imaging studies. And they identified that, all this, the oleum loss, etc., will correspond to, the olfactory cortex. And once your the sense of smell, etc., return, the brain oleum also returns to normalcy. So basically, this study is more about the immunopathogenesis of COVID-19. Now we know more about the why these sort of symptoms are occurring and lot of treatment, how the patient should be worked up, etc. So thank you for this opportunity.
Thank you, Dr. Aravind sir, for that unparalleled learning experience. So comprehensive and precise, and a lot of things to ponder and practice also. Well, we know that General Hospital Trivandrum was one hospital which first started these post-COVID clinics and all. And Dr. Shyamsundar sir was very much there during the COVID management, the ICU management, the ward management, and as well as the management of the long COVID syndrome. And I think it will be worthwhile. It will be most worthwhile to know from the practicing physician to know his thoughts about the article, the presentation, as well as his experience in managing long COVID, and throw light on it. Over to Dr. Shyamsundar sir.
Thank you, Dr. Anju. And especially thank you for Dr. Aravind. So bringing out this article to us. This is a extensively written and extensively researched article. Of course, there's a lot of things come out from the COVID and its pathogenesis. Actually, if you look at the article, and actually you look at the symptoms of COVID, all symptoms in the world has been attributed to COVID now. Are we overdoing COVID like this? We have, of course, pathological mechanisms where the COVID can influence, an infection can influence. Why it is so elaborate in this infection only? If it is so, why the coronaviruses earlier did not produce such an extensive symptomatology now? For the last 2 years, we have nothing else to do but just to research on COVID. So everybody was putting papers and searching on COVID alone. All the other systems are set aside and only COVID exists. Actually, we are blaming everything to COVID. Because there are so many symptoms, it's very difficult to explain otherwise. Chronic fatigue syndrome and encephalomyelitis, all these things. Previously, there was also there, but we are difficult to explain in what condition and what causes all these things. And we are looking for something to blame, and we got COVID. Is this the scenario now? I am yet to find out that there is an answer. If the people are also happy, if you attribute all these things to COVID, they have some advantages and something they can blame. And doctors are also happy. But are we going on the right track? That is something to ponder about. We heard COVID is an extensive thing and everything. Media, government, and the people has just emphasized the presence. I think we are, my personal opinion, we are overdoing about the COVID infection and all that. I would like to know your interpretations and your view on this.
Sir. I think that, yes.
Actually, it's a very difficult question to answer because, for example, in the Kerala context, probably around 3.5 crore people would have got COVID-19. And as Sarah said, attributing everything, like say a patient is presenting with arterial vasculitis and all. And if you are looking at the COVID antibody, it will be positive. All of us, it will be positive. And can be attributed to, say, COVID-19 or it's something else, it's very difficult to say. Because majority of the autoimmune things or autoinflammatory things, now we are finding COVID to blame. To an extent, that is right. But then certain things like, say, multisystem inflammatory syndrome in children and multisystem inflammatory syndrome in adults, etc. After COVID-19, definitely. So we were not experiencing to this extent this multisystem inflammatory syndrome in children. You have this atypical Kawasaki, which is a close mimicker. But then COVID to an extent can trigger a lot of autoimmune as well as autoinflammatory conditions. And that is our experience because over the last 2 years, we are facing a lot of issue with regard to atypical manifestations with these autoinflammatory conditions are presenting, as well as the IBD, which is presenting after COVID-19. But then as Sarah said, this post-COVID, almost all the manifestations are there following a severe COVID, dengue as well. But the only difference which we could find was that, in majority of the viral illness, all these, the manifestations are occurring following severe dengue and all those things. And that is there in COVID. But then following a mild dengue and all, are we seeing this much of, like, say, brain fogging and all? I am not really sure. But then studying this is going to be very difficult because all of us would have had COVID multiple times. And can we blame all the manifestations to COVID-19? It's very, very difficult to say. And that is why I said that these sort of assumptions or this the associations can be made only if we are having a very good electronic health record system like in Denmark or UK, like that. But blaming everything on COVID is also not right. That's true. I totally agree with Shamsundar sir.
Thank you, Arvind sir. Shamsundar sir, can we go on to the analysis part of the journal also, sir, right now? I think Dr. Ramesh Raja sir is very much with us. Sir is assistant professor of at the Department of Community Medicine. So anyway, this is a paper that has been published and all, and we are all are interested in the analysis of the paper as such also. Even though we have given the due importance which it deserves regarding the clinical aspects more, we would also like to hear from Dr. Ramesh Raja sir regarding the paper, its quality, whether it was properly conducted. I mean, this analysis and all. So over to Dr. Ramesh Raja sir. Sir.
Okay, thank you, sir. So overall, as Arvind sir has duly mentioned, it is a very high impact factor journal with around 76 impact factor. And as you can say, it is a review article. Review article itself has its limitations and has its advantages. Being the most advantage is you can pull up numerous studies. So they have duly gone into the different studies. They have duly reviewed many journals in per se, and major findings were put forward from these journals, which have a large number of study participants altogether.
Ravi sir, sorry to interrupt, sir. Can you be a little louder, sir? Can you be a little louder also?
Yeah, am I audible now more?
Yeah, perfect, sir. Thank you so much, sir.
Okay. Sorry for that. So this review article, as you know that unlike other observational studies or RCTs, review articles per se doesn't have a strict critical appraisal protocol. So it basically we have to look into how many articles they have reviewed, how recent they are, and how they have interpreted. So as far as this article is concerned, they have duly gone into the many important aspects of the study, especially with the pathogenesis and also with the impact of the long COVID. So they have duly mentioned about the hazard ratio altogether with appropriate representation all the way. So per se, if you can say it is a good review article altogether with more emphasis. Then as Sarah raised certain concern regarding whether everything is attributed to COVID, that still is there. But if you look into it, as Arvind sir has properly mentioned, there is a higher incidence of the symptomatology among the people presenting in the clinics. So if you look into that aspect, so before 2020, even though there may be an overrepresentation of symptoms into the COVID, but still overall the frequency of the symptomatologies and manifestations, especially the clinical manifestation like cognitive fogging and everything, has raised in the world. So COVID has an impact on the general population per se.
Thank you, sir. I think before we go on, there are a few questions in the chat box. We'll probably address those ones. Arvind sir, the first question is long COVID benefited by 3 doses of vaccine? I think we have already discussed that fact, but still, sir.
Actually, we have differing evidence on that. This study does not look into that aspect. But then there is a preprint from the US Veterans Association group, which looked at the number of reinfections and the occurrence of these post-COVID symptoms. In that, actually, the number of doses of vaccine had no effect on the occurrence of post-COVID symptoms. So I think that since, the vaccines cannot prevent infection per se, even mild infections can lead to post-COVID manifestations. The number of doses and the occurrence of long COVID, I don't think that it is beneficial.
Okay, thank you, sir. And another question is, are there any predictive markers for patients who might go on to long COVID? I think sir has mentioned few risk factors. No, sir?
Yeah, predictive biomarkers are there. One thing I did show, that is in CSF, if you're looking at the CXCL11 and all, if it is elevated, the chance of brain fogging is going to be higher. So majority of the biomarkers are like that. That is in the experimental, in the lab, etc. We may be able to look at this the inflammatory biomarkers. So this article does mention some biomarkers like that, but in real practice, we may not be able to do such things.
Thank you, sir. Now, the forum is open for discussion. If anybody would like to discuss anything, to point out certain points or to contribute to the discussion, kindly unmute and they can unmute and contribute.
Regarding the third dose vaccine question, this study was mainly, or this review article was is really focusing on patients with long COVID who developed the symptoms following this mild acute COVID-19. Okay, suppose the patients are having severe COVID-19, then the symptomatology is going to be entirely different. For example, patients who develop and pneumonia is on ventilator, etc. After recovery, the dyspnea, etc. might persist for months or years together. In that aspect, that is, the long COVID symptoms following severe COVID-19, definitely the third dose of vaccine is going to be beneficial, because the severity of the infection can definitely be decreased by the third of the dose of the vaccine, especially those who are vulnerable, like people above 65, those with comorbidities, etc. So the more severe the COVID-19 is, the chance of them progressing to long COVID is also going to be more. In that aspect, the third dose is beneficial. I said that it's not beneficial when looking at the patients who are progressing to long COVID following mild COVID-19. In that scenario, the third dose is not going to be beneficial.
Okay. Dr. Shyamsundar sir, I think I have one opinion to make actually before. Like sir was telling about the risk of attributing every symptoms to COVID and all. But I was thinking in the opposite way actually, sir, because we are now not even testing that much and all, and we are seeing symptoms also. I also see adults in OP and all, in health services, etc., etc. But do we really think about the link with the COVID, and are we trying to connected with the COVID, this thing actually, because sir has been telling many the symptomatology was so vast that as Ravi sir was telling, these are the symptoms that we see regularly in our OP and R. So every time, whether we are really giving an effort to connect it to COVID, and whether we are offering the spectrum of management sir was telling and all, that also was, I was just wondering, sir. Sir, what do you think, sir? That also should be considered, no, sir? Because as a physician, sir may be in a better position, but
I agree with you. Previously, before the COVID, we have at a dilemma how to attribute these symptoms. We used to have some depression and all that. We used to attribute. Now we have something to tell about, and people are happy to have that answer. So we are also stopping there. So are we actually, is it truthful that we stop at that place? We should have been encouraging much more research and more studies about this. Other actually we are seeing the COVID in the forefront or something else in behind. So the viral infections are there, time immemorial. Whenever there is infection, the viral infections are there. But suddenly all this the scenario has changed. So have we changed our genetic makeup has been changed, or the viral makeup has changed? Something has happened to us, but actually we do not know. It is time to come, and we have to decide what exactly is happening now. Thank you.
Thank you so much, sir. Now, one doubt I wanted to clear with Ramesh Raja, sir. Actually, sir was telling about the impact factor of journals also, sir. But what I understand is that there is a number of references and articles being referred in other articles or that. So, does this impact factor? I mean, I'm not at all trying to tell anything about the quality of this thing, but just to clear that, because I was telling about this impact factor somewhere else, and they had immediately asked me that is there really anything? So. Does the impact factor, of course, it would be a factor in determining the quality of the article and the journal. But, sir, are there any other, criteria with which whether we can tell that an article is of an ace quality or something like that? Other than the impact factor? I was just asking a general question, sir. Ravi, sir, can you please attempt the question, sir?
Okay, as you can see, impact factor has an major contribution, because it is one of the scales with which We know
Sir,
that
requesting to be a bit louder, sir. Thank you,
okay,
sir.
impact factor has a very significant role in assessing the quality of the journal per se, because it has been used universally over it. Because it is, when you consider it is just as number of citations, you can't say just like that, because impact factor considers into number of exogenous citations as well. It's not within the citations within that journal for the past 2 years, but it also takes into account how many outside has been cited, because that is self-citation is one of the concern that most of us have, and few journals tend to say that impact factor based on the self-citation. So it is only one of the things we can hold on to identify that the quality of the
Okay.
journal person.
Yeah. That's it, sir. One more question is, sir, that regarding the papers that has been analyzed in this particular journal, are they really telling the source of those articles and or in a tabular form or something like that, or is it?
Well, in the reference part, they have clearly mentioned, and
Okay.
citations, comments they have made. If you look into the journals per se, one thing we can identify whether the quality of the article is wherever you see a references, we can look into the reference article per se and whether they have addressed the issue properly. So by looking into
Yeah,
that also,
understood, sir.
especially
Thank you, sir.
whenever we have a concern about a particular pathology that is being discussed in the journal and it has been referred, we can actually look into that journal and understand more about it.
That is true, sir. Thank you so much, sir. Dr. Arvind, sir, I have one doubt here, sir. Sir was clearly explained regarding the pacing part, how that as far as this physical part is concerned. But sir was also mentioning about cognitive pacing, but sir just mentioned that only, sir. So how do you do that cognitive pacing? I was just.
Actually, no, I'm not an expert in this doing this cognitive pacing and all those things. And to be frank, only after reading this article, I came across this term cognitive pacing. So cognitive pacing really means that basically you are having sort of an executive dysfunction, right? So in order to trigger your various areas of the brain, you are asked to do certain exercises like memory exercises and all those things. So that is basically cognitive pacing. The physical pacing means that no, you have to rest for a particular period of time, and then you have to sort of a work-rest balance. Work-rest balance is physical pacing. Just like that, when cognitive pacing is also like not thinking about a lot of things for a particular period of time and then exercising your brain like that. That is basically cognitive pacing. And I would like to add to what Shamsundar sir did say initially, because no other disease have been studied to this extent like COVID-19. Okay, for 2 to 3 years, almost everyone in the sense that not only the researchers in medical field, even the mathematicians, everyone was doing research on COVID-19 because they had nothing else to do, because majority were being locked down and all those things. And that is the reason why, when we're looking at the immunopathogens and all those things, it seems like a very different disease. Suppose we are studying, say, dengue or leptospirosis to the same extent. We don't know why, youngsters are dying due to a 10% of leptospirosis patients will progress to Wheel syndrome. 90% are having anictic leptospirosis. So rather than the pathogen, it is basically the immune response. Okay, that decides the outcome of leptospirosis or dengue hemorrhagic fever like that. But it has not been studied to that extent like COVID-19. Basically, my take home is that COVID-19 has been studied to that extent that whatever we have learned from COVID-19, we may have to do research on other infections and to see whether the same thing applies there. For example, during 2017, we had a major outbreak of dengue. During that time also, the myocardial infarctions did go up. So the similarity between dengue as well as COVID is that both affect the endothelial system, right? So basically, both are endotheliopathies. So any infection which can lead to an endotheliopathy might lead to an increase in occurrence of, say, a myocardial infarction or stroke syndromes. So might not be limited to COVID-19 per se. And COVID affected such a large population, means, maybe everyone was affected, so that we are coming across bizarre manifestations, because the way in which different immune systems responds to the same viral trigger is going to be entirely different. And adding to the challenge, for the last 2 years, we knew who had COVID. But this year, we have no idea, because the testing levels have gone down a lot. We had a 17-year-old girl who presented with high-grade fever of 103, 104 degree Fahrenheit. And the history goes like this. She went to Chandigarh and then along with her sister and mother, she came back with high-grade fever. And then the tests were done, and typhoid or IgM and brucella both were positive. So what will we think? A travel history is there and typhoid or IgM is positive. So it was initially treated as enteric fever from some other hospital and there was no response. And then the fever continued to be very high. Okay. Other organ systems were not affected. She went to multiple hospitals and even after 1.5 months, the fever persisted like this and then came to us. Now, actually, COVID was never done, right? Okay. And the history goes like this. Her sister was having an autoimmune disease. There is vaginous granulomatosis, and they had gone to Chandigarh to consult a rheumatologist in PGI Chandigarh. At that time, the sister had COVID-19. She was tested because she is immunocompromised, right? And then 1 week later, her sister, that is the current patient, also developed fever, sore throat, etc., but was not tested. And then the fever never came down and persisted like that. So basically, she was also having COVID-19 and the fever persisted for around, say, 1.5 months. And then she started developing cluster headache, the classical cluster headaches. Okay. And everything responded to the steroids. The fever came down, the cluster headache, the symptomatology, everything started improving. So cluster headache has also been described as a post-COVID complication because now there are 200 symptoms are there, which includes cluster headache also. And the chance of, when looking at our discussion, the chance of patients who are having an autoimmune milieu developing this sort of immune dysregulation following the SARS-CoV-2 viral trigger is high. So when you are looking at her family history, her sister is having vaginous granulomatosis. So if there is a sibling with vaginous granulomatosis, the other sibling is at a high risk of or has a high propensity of developing not vaginous, but some other autoimmune disease. So this is the group which might have, autoimmune flare or say dysregulation following a viral trigger. So this is actually the challenging situation because we are not performing SARS-CoV-2 now, and we are missing all sorts of mild cases. I'm not saying that we should test. Only thing is that if someone is presenting with high-grade fever or with an elevated inflammatory markers, the question we need to ask is that, is there a clustering of respiratory ILA-like symptoms in the family in the last 1 month or so? If there is a clustering of ILA-like symptoms, we have to assume that probably the trigger could have been COVID-19.
And sir, what about the management also? Because sir was telling about that management in with naltrexone, coenzyme Q and all. Sir has been doing these things. So, if one of our colleague diagnoses this, and is it safe to start these drugs and manage?
This is actually from the article, right? No, the treatment modalities are from the article. It's not what I do, etc. So what we do is that, suppose the patient is having non-refreshing sleep, insomnia, etc. Probably we have to refer the patient to the psychiatrist. Okay, they will start with melatonin and all those things and all like that. Coenzyme Q for fatigability we are prescribing. Okay, usually if the infections are rolled out and all the inflammatory markers are elevated, there is no harm in trying immunomodulators like say colchicine, hydroxychloroquine, and if there is no response, steroids. But the tricky aspect is just like a patient is having abdominal pain and the imaging is showing ileal thickening with mesenteric adenitis. Will you diagnose as a post-COVID inflammatory bowel disease, or will you think of ruling out tuberculosis? So that is going to be the problem. So we need to rule out infections prior to starting these immunomodulators. Because we have burned our fingers. We have burned our fingers many times by starting steroids and later it turned out to be tuberculosis. Okay.
Yes, a very well taken point, sir, actually. And I think these post-COVID clinics and all those things which were initially very, aggressively started. And I think it is a high time to rejuvenate it and make it a routine, this thing, and maintain. And also because Shyam sir was also telling about this follow-up of these patients and all, and the studies which would have been conducted and all. So that would go a long way regarding the management, the knowledge of this post-COVID syndromes as far as we are concerned. Because it's academical, this studies can be done in the health service as well as in the private sector also. And thank you once again for Arvind sir because we all of us were telling that a number of studies were being done as far as COVID, as far as long COVID is concerned. To find out a such a beautiful article which comprehensively depicts every aspect of this and beautifully taking that information to us for this time. Everything, sir. From my part as well as from the team, I express my sincere gratitude and I hand over the mic to Dr. Pradeep Kadangur, sir.
Thank you. Thank you.
സാർ എനിക്കൊരു സമയം ചോദിക്കാവോ ഡോക്ടർ പൈ?
തീർച്ചയായിട്ടും സർ.
ഒന്ന്, ഈ ഞങ്ങളെ പോലെയുള്ളവർക്ക് ന്യൂട്രോഫിൽസ് ലിംഫോസൈറ്റ് റേഷ്യോ നോക്കിക്കഴിഞ്ഞാൽ വളരെ ലിംഫോപ്പീനിയ ഉണ്ടെങ്കിൽ അത് കോവിഡ് പോസിറ്റീവ് ഇതേപോലെയുള്ള സിംറ്റംസിലോട്ട് നയിക്കത്തില്ലേ? ഒന്ന്, ന്യൂട്രോഫിൽസ് ടു ലിംഫോസൈറ്റ്സ് അത് വളരെ ഇതായിട്ട് വരികയാണെങ്കിൽ നമുക്ക് ചോദിക്കാം, ഇങ്ങനെയൊക്കെ പ്രോബ്ലം വരുമെന്ന് പറയാൻ പറ്റത്തില്ലേ എന്ന് ഞാൻ ഒരു ചോദ്യം ചോദിക്കുന്നു.
സാറേ, ആക്ച്വലി നമുക്ക് NLR എന്ന് പറയുമ്പോൾ സിവിയറിറ്റിയുടെ മാർക്കറാണ്. അപ്പൊ NLR മീൻസ് ലിംഫോസൈറ്റ് കുറഞ്ഞു വരുന്ന അനുസരിച്ച് സിവിയറിറ്റി കൂടും. സിവിയറിറ്റി കൂടുന്ന കോവിഡിന് ഡെഫിനറ്റ്ലി ലോങ് കോവിഡിലോട്ട് പോകാനുള്ള ചാൻസ് വളരെ വളരെ കൂടുതലാണ് സർ. ഈ ആർട്ടിക്കിളിന്റെ ഫോക്കസ് ഈവൻ മൈൽഡ് കോവിഡ് ഉള്ള ആൾക്കാർക്കും ലോങ് കോവിഡ് വരാം, അതിന്റെ ഇമ്മ്യൂണോ പത്തോജൻസിനെ പറ്റിയാണ് കൂടുതൽ ഡിസ്കസ് ചെയ്തത്. സാറ് പറഞ്ഞ കറക്റ്റ് ആണ്. NLR കുറയുന്ന മീൻസ് ലിംഫോസൈറ്റ് വരുന്ന അനുസരിച്ച്, അതായത് NLR കൂടി വരുന്ന അനുസരിച്ച് സിവിയറിറ്റി കൂടാൻ ചാൻസ് ഉണ്ട്. അത്തരം ആൾക്കാർക്ക് ലോങ് കോവിഡ് വരാനുള്ള ചാൻസ് വളരെ ഹൈ ആണ്.
രണ്ടാമത്, ഈ ചൂടായ ചായ 5 or 6 കപ്പ് കൂടുതൽ കുടിക്കാൻ പറഞ്ഞാൽ പലരുടെയും ഈ ഫാറ്റീഗ് മാറിയതായിട്ട് കാണുന്നുണ്ട്. എന്റെ ക്ലിനിക്കൽ എക്സ്പീരിയൻസിൽ. വാട്ട് ഈസ് യുവർ ഒപ്പീനിയൻ?
സർ, മീൻസ് ഡീഹൈഡ്രേഷൻ കറക്റ്റ് ആവുന്നുണ്ടോ അറിയത്തില്ല, ബട്ട് റിയലി ഐ ഡോണ്ട് നോ.
The third thing, I am now 80 years. I have taken 3 doses. I am also diabetic. ഇനി ഞാൻ ബൂസ്റ്റർ എടുക്കണോ വേണ്ടയോ എന്നൊരു ചോദ്യം എന്റെ.
സാർ, ഇപ്പോഴ് ഇമ്മ്യൂൺ ഇംപ്രിന്റിങ്, അതായത് ഒറിജിനൽ ആന്റിനിക്സ് എന്ന് പറഞ്ഞൊരു രീതിയിൽ NEJM-ൽ ഒരു ആർട്ടിക്കിൾ വന്നിട്ടുണ്ട്. അതായത് 4th ഡോസ് മീൻസ് എടുത്തുകൊണ്ട് മീൻസ് ഒരു പ്രത്യേക ബെനിഫിറ്റ് ചിലപ്പോൾ വന്നൊന്നും വരത്തില്ല സർ. 3 ഡോസസ് സാറിന് ഇൻഫെക്ഷൻ വന്നിട്ടുണ്ടോ?
ഇല്ല ഇല്ല.
Okay. So I think as per the current evidence, 3 doses are enough for you.
Yes, thank you for this. ഇതൊന്ന് ട്രൈ ചെയ്ത് നോക്കുന്നത് നന്നായിരിക്കും. വളരെ ചൂടുള്ള ചായ കുടിപ്പിച്ചു കഴിഞ്ഞാൽ പലർക്കും ഇതിന്റെ ഈ ചുമയും അതുപോലെ ഡ്രൈ കോഫും അതുപോലെ ഫെറ്റീഗും മാറുന്നതായിട്ട് ഞാൻ കണ്ടിട്ടുണ്ട്. സാറ് ഒന്ന് ട്രൈ ചെയ്യുന്നത് നന്നായിരിക്കും. I am a physician, graduated from Trivandrum Medical College 1970.
Thank you, sir.
Thank you very much for listening to me.
Thank you, sir.
So thank you, Dr. Anju, Dr. Aravind, Dr. Shamsundar sir, and Dr. Ramesh Raja. I think Dr. Altaf is joined. Dr. Altaf.
Sir.
A few words. Our secretary, very vibrant, very dynamic secretary for IMA Trivandrum branch, Dr. Altaf. Few words.
അല്ല, ഞാൻ സാർ ഈ കോണ്ടാക്ട് എനിക്ക് മനസ്സിലായില്ല. ഞാൻ ജസ്റ്റ് ഇങ്ങനെ കയറുന്നേ ഉള്ളൂ. ഇത് കഴിഞ്ഞോ? അരവിന്ദിന്റെ പ്രസന്റേഷൻ കഴിഞ്ഞായിരുന്നോ? കഴിഞ്ഞല്ലേ? ഓക്കെ. കോവിഡ്, പോസ്റ്റ് കോവിഡ് റിലേറ്റഡ്. ഓക്കെ. അപ്പം എന്തായാലും ഇതിപ്പം നമ്മൾ വൈൻഡപ്പ് ചെയ്യാണോ പ്രോഗ്രാം?
അതെ.
ഓക്കെ. ഞാൻ ജസ്റ്റ് കയറുകയായിരുന്നു, ജസ്റ്റ് ജോയിൻ ചെയ്തേ ഉള്ളൂ. അപ്പം എനിവേ എനിക്ക് തോന്നുന്നു ഇപ്പൊ തന്നെ മോർ ദാൻ 30 പാർട്ടിസിപ്പൻസ് ഇപ്പോഴുണ്ട്. സോ ഈ IMA Trivandrum ബ്രാഞ്ചിന്റെ AMS ആക്ച്വലി വളരെ വൈബ്രന്റ് ആയിട്ട് നമ്മൾ തുടങ്ങിയത് മുതൽ തന്നെ ആക്ച്വലി എനിക്ക് തോന്നുന്നു ഈ കഴിഞ്ഞ 3 മാസത്തിനിടെ ഏറ്റവും കൂടുതൽ പ്രോഗ്രാംസ് കണ്ടക്ട് ചെയ്തിരിക്കുന്നത് AMS ആയിരുന്നു. അത് പ്രദീപ് സാറിന്റെ ഇനിഷ്യേറ്റീവും ഇൻട്രസ്റ്റും എഫേർട്ടും എല്ലാം അക്കാര്യത്തിൽ നമ്മൾ സ്പെസിഫിക് ആയിട്ട് പറയേണ്ടതുണ്ട്. പിന്നെ എനിവേ IMA-യുടെ ഒരു ഫൗണ്ടിങ് ഒബ്ജക്റ്റീവ് തന്നെ മെഡിക്കൽ സയൻസിന്റെയും മെഡിക്കൽ എഡ്യൂക്കേഷന്റെയും അലൈഡ് സ്പെഷ്യാലിറ്റീസിന്റെയും ഒരു പ്രോഗ്രസും ഡെവലപ്മെന്റും ഒക്കെ ആക്ച്വലി അതിന്റെ ആ ട്രൂ റിഫ്ലക്ഷൻ ഓഫ് IMA ഫൗണ്ടിങ് ഒബ്ജക്റ്റീവ്സ് ഉള്ളൊരു ആക്ടിവിറ്റി ഏരിയ ഓഫ് ആക്ടിവിറ്റി AMS നടത്തിക്കൊണ്ടിരിക്കുന്നത്. അത് തീർച്ചയായിട്ടും നമുക്കെല്ലാം ബെനിഫിഷ്യൽ ആയിട്ടുള്ള കാര്യമാണ്. അതിൽ തന്നെ വളരെ ഡൈവേഴ്സ് ഇപ്പൊ തന്നെ ഓൺ സൈഡ് ജനറൽ ക്ലബും ക്ലിനിക്കൽ ക്ലബും കണ്ടക്ട് ചെയ്യുന്നു. അതിന്റെ ഓൺ ദ അതർ സൈഡ് ക്ലിനിക്കൽ സ്കിൽസ് ട്രെയിനിങ് അടുത്ത ആഴ്ച അത് ഷെഡ്യൂൾ ചെയ്തിട്ടുണ്ട്. ഇങ്ങനെ ഒരുപാട് വൈബ്രന്റ് ആയിട്ടുള്ള വളരെ യൂസ്ഫുൾ ആയിട്ടുള്ള എല്ലാവർക്കും ഒരേ സമയം യങ്സ്റ്റേഴ്സിനും സീനിയേഴ്സിനും എല്ലാവർക്കും യൂസ്ഫുൾ ആയിട്ടുള്ള ഒരുപാട് പ്രോഗ്രാംസ് AMS കണ്ടക്ട് ചെയ്യുന്നുണ്ട്. അതുപോലെ പൈപ്പ് ലൈനിലുണ്ട്. എന്തായാലും അതിനുവേണ്ടിയുള്ള എല്ലാ എഫേർട്സിനും പ്രദീപ് സാറിനെ അഭിനന്ദിക്കുന്നു. അതിനോടൊപ്പം ബ്രാഞ്ചിന്റെ മുഴുവൻ ഫോഴ്സും മുഴുവൻ നമുക്ക് നമ്മുടെ വർക്ക് ഫോഴ്സും ഉള്ളതിന് സപ്പോർട്ടും കൊടുക്കുന്നതായിരിക്കും. അതുപോലെ ബാക്കി എല്ലാവരുടെയും പാർട്ടിസിപ്പേഷൻ, ഇനിയുള്ള പ്രോഗ്രാംസിനും എല്ലാവരുടെയും പാർട്ടിസിപ്പേഷനും. അത് ആക്ച്വലി ഈ ഏത് പ്രോഗ്രാം കണ്ടക്ട് ചെയ്യുമ്പോഴും ആ പ്രോഗ്രാമിന്റെ എത്രത്തോളം നമ്മൾ ഏത് ഫാക്കൽറ്റി ഉണ്ടെന്നോ എന്തൊക്കെ കണ്ടന്റ് ആണെന്നുള്ളതിനേക്കാൾ ഉപരി മോസ്റ്റ് ഇമ്പോർട്ടൻറ്റ് തിങ് ഈസ് പാർട്ടിസിപ്പേഷൻ. അപ്പം നമ്മൾ ഏറ്റവും കൂടുതൽ ഫോക്കസ് ചെയ്യേണ്ട ഒരു കാര്യം അതാ. നമുക്ക് ശരിക്കും ഓരോ ടോപ്പിക്കിന്റെയും ഇൻട്രസ്റ്റഡ് ആയിട്ടുള്ള ഒരുപാട് ആൾക്കാരുണ്ടാവും. അവരിലേക്ക് ആ കമ്മ്യൂണിക്കേഷൻ കൃത്യസമയത്ത് എത്തുക എന്നുള്ളതാണ് ഏറ്റവും പ്രധാനം. അപ്പൊ അത്രയും കാര്യങ്ങളാണ് നമ്മൾ ഓഫീസിൽ നിന്ന് ബാക്കപ്പ് കൊടുത്തുകൊണ്ടിരിക്കുന്നത്. ഓരോ പ്രോഗ്രാമിന്റെയും മാക്സിമം പാർട്ടിസിപ്പേഷൻ ഉണ്ടാക്കാൻ പറ്റുന്ന രീതിയിലേക്ക് ഇൻട്രസ്റ്റ് ആയിട്ടുള്ള എല്ലാവരെയും അതിനകത്ത് നമുക്ക് കമ്മ്യൂണിക്കേറ്റ് ചെയ്യാൻ പറ്റുക എന്നുള്ളത്. എന്തായാലും സാറിന്റെ ഈ ഇനിഷ്യേറ്റീവ് AMSന്റെ അതുപോലെ ആനന്ദം രണ്ടുപേരും നടത്തുന്ന എഫേർട്സ് ഈ പ്രോഗ്രാം വളരെ നല്ല രീതിയിൽ നടക്കുന്നതിന് വേണ്ടിയുള്ള എല്ലാ ആശംസകളും അഭിനന്ദനങ്ങളും പിന്തുണയും എല്ലാം അറിയിക്കുന്നു. അതോടൊപ്പം ഡോക്ടർ അരവിന്ദ് നമ്മുടെ പ്രിയ സുഹൃത്തും അതുപോലെ വളരെ എമിനന്റ് ആയിട്ടുള്ള ഒരു ഫാക്കൽറ്റി. ഇപ്പം ശരിക്കും പറഞ്ഞാൽ ഇൻഫെക്ഷസ് ഡിസീസ് എന്നുള്ള ഒരു ഡിപ്പാർട്ട്മെന്റ് ട്രിവാൻഡ്രം മെഡിക്കൽ കോളേജിൽ ഉണ്ട് എന്ന് എല്ലാവരും അറിയുന്നത് തന്നെ. നേരത്തെ ഉണ്ടായിരുന്നു, 10-25-30 വർഷമായിട്ടുണ്ടായിരുന്നു. അത് അതിനു മുമ്പും ശരിക്കും വളരെ സീനിയർ ആയിട്ടുള്ള ഒരുപാട് ലെജൻഡറി ആയിട്ടുള്ള ടീച്ചേഴ്സ് ഒക്കെ ഉണ്ടായിരുന്നു. തീർച്ചയായിട്ടും അവരെല്ലാവരും ഒരുപാട് കോൺട്രിബ്യൂഷൻ നടത്തിയിട്ടുണ്ട്. പിന്നെ ഇപ്പൊ ഈ എമർജിങ് ഇൻഫെക്ഷൻസ് ഒക്കെ വന്നതുകൊണ്ട് തീർച്ചയായിട്ടും ID ഡിപ്പാർട്ട്മെന്റിന് വലിയൊരു കീ റോളുണ്ട്. അത് വളരെ നല്ല രീതിയിൽ ഡോക്ടർ അരവിന്ദ് ചെയ്യുന്നുണ്ട്. അരവിന്ദിന് പ്രത്യേക അഭിനന്ദനം. പിന്നെ ഇപ്പൊ അൺഫോർച്ചുനേറ്റ്ലി എനിക്ക് ഈ പ്രോഗ്രാം വേറെ 1-2 മീറ്റിങ്ങുകളിലായതുകൊണ്ട് ഇതിൽ അറ്റൻഡ് ചെയ്യാൻ പറ്റില്ല, സോറി. എന്തായാലും എല്ലാവർക്കും താങ്ക് യു.
Thank you so much,
Pradeep
sir,
sir.
for the next words.
Pradeep sir.
Thank you so much.
Pradeep sir. So ഒരു കാര്യം കൂടെ അരവിന്ദ് സാർ അതുപോലെ തന്നെ നമ്മുടെ ആർട്ടിക്കിളിലെ റിയാക്റ്റീവ് എയർവേ ഡിസീസിനെ കുറിച്ചിട്ട് എടുത്തു പറയുന്നില്ലായിരുന്നു. എങ്കിലും മുമ്പ് ഇതുവരെ ഈ പറഞ്ഞ റിയാക്റ്റീവ് എയർവേ ഡിസീസ് ഇല്ലാത്തവർ കോവിഡ് വന്നതിന് ശേഷം പ്രസന്റ് ചെയ്യാനും കുറെ കാലം ഇതുപോലെ ഇഷ്യൂസ് ഇല്ലാത്തവർ വളരെ സിവിയർ ആയിട്ടുള്ളതോ അല്ലെങ്കിൽ സിഗ്നിഫിക്കന്റ് ആയിട്ടൊക്കെ വരുന്നതുമായിട്ടും കാണുന്നുണ്ട്. അതിക്കൊന്ന് ഒത്തിരി സ്റ്റഡീസ് ഒക്കെ അതിനെക്കുറിച്ച് ഡിസ്കഷൻ ഒക്കെ നടത്തിയിട്ടുണ്ടെന്ന് തോന്നുന്നു. അതും ശരിയാണല്ലോ അല്ലേ സാർ? അങ്ങനെ
അല്ല, ഈ ആർട്ടിക്കിളിലും അത് ഉണ്ട് കേട്ടോ. ഞാൻ ആക്ച്വലി നമ്മൾ യൂഷ്വലി ഡിസ്കസ് ചെയ്യാത്ത കാര്യങ്ങൾ മാത്രമേ എടുത്ത് പ്രസന്റ് ചെയ്തുള്ളൂ. അതായത് ഇമ്മ്യൂണിറ്റിയിലോട്ട് ഫോക്കസ് ചെയ്യും. എല്ലാ സിസ്റ്റത്തിനെ പറ്റിയും ഡീറ്റെയിൽഡ് ആയിട്ട് ഈ ആർട്ടിക്കിളിന്റെ അകത്തുണ്ട്. ലെങ്ങിനെ പറ്റി എല്ലാം ഡീറ്റെയിൽഡ് ആയിട്ടുണ്ട്.
Okay, sir. Pradeep sir.
Thank you so much, Dr. Aravind, for the selection of article. That was an excellent article that covered everything, and your discussion was excellent as expected, and that was great. And this was a wonderful session, and this shows that a lot of effort, studies are to be made to find out more and more about COVID and post-COVID. Okay, more studies. I think probably Dr. Aravind must be doing a lot of studies in medical college. Anyway, it was a wonderful session, and Dr. Shamsundar sir and Dr. Ramesh Raja for participating, your contribution, and Dr. Anju Kanmani. Without you, it wouldn't have been possible to conduct this journal club. You are doing an excellent job. Actually, there was a stage when we thought of postponing it to next month, but Anju was very particular that this should be done this month, because this month we didn't conduct the journal club, sir. You shouldn't have the break in the chain. Thank you, Anju. That's very encouraging. And
because of Arvind sir only, sir. Because of Arvind sir only.
Yeah. And thank you, Dr. Vijaykrishna and Dr. Altaf, for that encouraging words. And all the participants. Even now we have so many participants now. Good. It's a very good, very good encouragement for all of us. And good night. We like to see you again for our next session. And next session, sir, probably before
winding up, sir, I think, sir, the article also should be circulated in the groups so that they can read the article as well as it, because this will be anyway uploaded in the YouTube channel. But if the article is also circulated, they can also read, and that was
fine. I'll do it. We have some good programs coming up. Like on 4th, we have that is a World Cancer Day. We are arranging, our AMS team, IMAMS team is arranging a cyclothon in the morning. And we have an excellent CME program in the evening, prevention of colorectal cancer by Dr. Rajiv Jaydev. It's yet to be announced in the group. So please, all of you, try to join and make it a big success. Thank you all. Good night.